Thanks, Dr. Levin. Thank you for the opportunity to present in grand rounds. So I chose this topic, really, I think it was a risky maneuver because I went over a topic that Dr. Black had recommended earlier. So please pretend at the end that you loved the topic, so I'm not in the doghouse after this. But yeah, essentially I'll be talking about frailty in GU cancers. I think this is a relatively, well, it's not really a novel area of research, but the biomarkers associated and the history of it is quite interesting. And I think we're going to explore a little bit what's out there in the surgical oncology domain, mainly, and generally, and mainly the GU cancers domain. And then we'll talk a little bit about the interventions or possible interventions at the end. So it is expected by in 30 years' time that up to 20% of the population will be elderly worldwide. And with this aging process comes comorbidities, as we all know, and decline in health, or what we term frailty. I spent a few hours looking for a definition for frailty, and I promise you there's several groups and societies and consortiums that looked at this and tried to define it with years of research, and actually there isn't one definition. I think the essence of everything that you can capture from everything that's been out there is it's an increase in vulnerability to any external stressor leading to an adverse health event. I think that sort of captures pretty much everything that's out there. And I know it's difficult to operationalize in clinical practice, but I'm using this figure just to give an idea of what may happen in let's say, a healthy adult who's independent, who has, say, a UTI, and you see the dip in their performance there in the green line, and the recovery from it is probably a matter of a few days with antibiotics. However, if you take that same illness and you apply it to someone in their in their late 70s or early 80s with multiple comorbidities, we see the dip is a lot deeper and the recovery process is a lot longer. It may involve, instead of a visit to the ER or family physician, it may be a visit to, an admission to a hospital and possibly even discharge to an institution rather than home. And it is estimated that the incidence is 10 to 20% in people above 65 and up to 40% in 80-year-olds. This will obviously increase the burden on healthcare and on us as clinicians, and this is particularly important in oncology as most of our patients are elderly. And I think cancer now is ahead of cardiovascular deaths in many countries in the first world. And generally, this frailty in a cancer patient leads to falls, disability, and ultimately to death in many of these patients. And from a cancer-specific risks, it adds chemotherapy intolerance, complications related to these treatments that they're given. And I will show you later how it affects disease recurrence and progression. So I'm going to delve a little bit deeper into the frailty paradigm. This could be, I could give easily a 3-hour talk on this, but I tried really to capture what's the main points out there. There's two schools of thoughts, or two main ways of looking at frailty. There's the Frailty Index, which was published in 2005 by Rockwood and colleagues in the Canadian Medical Association Journal. And essentially, it's a count of accumulated deficits across various domains for these patients. And there is the Fried model, which is the frailty phenotype. And it's a relationship between a set of 5 criteria and outcomes. Now, this initially, when it came out, it helped people quantify frailty, or at least to start to quantify frailty. And this is just the diagrams illustrating the domains that are looked at in both Rockwood Frailty Index and the criteria for the definition in the Fried phenotype. Now, why is this important? I mean, does it impact anything? Well, from our point of view as surgeons, it does indeed. It does impact, it does have a lot of impact in the preoperative settings. This was one of the earlier studies that combined the frailty phenotype with the ASA score and looked at frailty in just under 600 patients. And it didn't indeed increase the risk for postoperative complications with an odds ratio of 2.5. It increased the length of hospital stay in the first 30 days and increased the incidence of discharging patients to assisted living facility after previously living at home with an odds ratio of 20. So it does affect us as clinicians from day-to-day basis. And since that publication, several others really echoed the same findings with higher incidence of complications, longer hospital stay, and higher 30-day mortality rate. Then Makelsak in 2016 published a paper showing long-term data of these patients where they followed them up for 12 months. And in the 13.6% of the frail population versus just under 5% of the non-frail died at 12 months following major non-cardiac surgery. And that cohort had about a third of urological procedures, mainly oncology. And this is just a diagram, or the graph, sorry, from their paper showing how these frail patients never really, it's not a smooth dip back to normality. It's really a very rocky course post discharge, and it doesn't really stabilize up to 12 months compared to a non-frail patient. So how do we screen for these patients, and how are we going to measure frailty? It's really difficult to do that, and I promise you there's a lot of work that has been done in this in the literature, and really the four main issues that are facing this is the absence of a definition that everyone accepts, and people look at it differently, or different clinicians or different researchers look at things differently. I mean, there's people who just want to assess it, people who are looking for ways of screening it, and probably people like ourselves looking at it as a predictor in postoperative, in the postoperative or the perioperative setting, and even longer or ultimately in the oncological setting. And the measurement tools vary. There's tens, if not hundreds, of different tools that assess or screen for frailty, and they do differ from a researcher to a lay research assistant using it, a geriatrician, to a physician or allied health professionals such as nursing on the floors and occupational and physiotherapists. And so far in the clinical setting, it hasn't really, going through medical school, I don't know about now, but going through medical school, I've never had, apart from a mini mental health test, to assess elderly patients. And I think it's still a niche geriatrician's role in the hospital to be able to quickly assess an elderly patient or a frail patient and give and try to predict the outcome or try to reverse some of these changes. Now, this is a table that shows different methods of measuring frailty. We have everything from gait speed to grip strength to things that are looking more at functional performance, and things that are looking at, that expand on that look at their physical health, also from a BMI and weight and albumin. And I'll come to those a little bit later. But you can see things are not just heading in one direction in this research domain. And this is evident by the number of things out there that are used to assess sarcopenia, as I mentioned. And there's a lot more than the things that are on this list, but they vary from just surrogate measures, these different scores and indices that are being used, to biomarkers that are looked at. And there's combined tools that combine a lot of those together to try and produce a score. But ultimately, they all lack the evaluation of clinometric properties. They're not reliable or valid, and certainly they don't all have the capacity to assess responsiveness to any intervention. And in reality, they're very cumbersome. To be able to measure in our clinic, to be able to look at someone's gait speed and grip strength, we'll probably need another clinic attached to ours to look at these things before we see the patients in our clinic, which really leaves the door open for further refinement, especially in our domain, in the surgical domain, due to the trauma or the stress applied from our end when we perform surgeries or put them on ADT or send them to medical oncology for chemotherapy. And, when you start delving more into this topic, you start finding other definitions and other clinical entities such as cachexia and sarcopenia, which both have been gaining a lot of attention recently. And people have sort of, especially in the surgical setting, have moved away from just looking at frailty and start defining what cachexia and pre-cachexia means, and where sarcopenia has a role in frailty or cachexia or not. And people have looked at that extensively in the last 10 years as a predictor for surgical outcomes. And the interaction between frailty and them is it's difficult to tease what's what when you read about it, and they really all overlap quite heavily, especially when we don't know what causes most of these conditions. I mean, apart from aging, we don't really know if there's other components to this frail state or cachexia. Well, I mean, in cachexia, we know there's cancer-related cachexia, but there's also cancer-related sarcopenia and cancer-related frailty. So it's very difficult to tease what's what. And I really liked this slide, which I borrowed from the European Sarcopenia Working Group publication in 2010, which was updated again in 2018. And it really looks at those three entities. And sarcopenia here is characterized by progressive loss of skeletal muscle mass and strength associated with adverse events. And when you compare that to frailty, it's a decrease in physiological reverse that ultimately results in adverse health events. And cachexia is, they added the metabolic component to it, associated with almost end-stage illness and loss of muscle and fat. So we see that there's a lot of overlap between them. And ultimately, I think they all share breakdown of muscle and protein and insulin resistance. It's not just a performance status thing. It also, I think there's a biological role there. And there's, I think the breakdown of the muscle also encompasses the other areas which they share, which is the grip strength and gait speed, in addition to the inflammatory or the immune component that is shared between frailty and cachexia. And I will tell you why later. I believe that muscle is probably the one thing that they all share and that could be used as a good surrogate or biomarker for these different clinical entities. So reversible of frailty and their surrogates, the interventions have focused, I think I lost my light. Just give me a second. Yep, I think I was too still. Sorry about that. But yeah, going back to interventions, historically everything has focused around nutrition, supplementation, and exercise. And they're all based on very sound theoretical basis of reversing muscle loss in frail patients. But especially that there's evidence that improving gait speed and muscle mass has improved outcomes in the surgical domain in those frail patients, and certainly in their publications. But is sarcopenia or loss of skeletal muscle the surrogate and the biomarker that we need to screen our patients and potentially reverse the negative effect? I'm gonna shift a little bit more towards sarcopenia in the rest of this talk, because I certainly believe that the loss of muscle is really the central component for all of these different states. And it is, as earlier mentioned, it's defined as a generalized and progressive loss of muscle function and muscle mass. And this is sort of the definition that's out there since 2010 by the European Sarcopenia Working Group. And we see it encompasses gait speed, grip strength, and then ultimately these two screening tools would lead you to investigate sarcopenia and investigate their muscle mass. This is the updated definition from the 2018 publication, which just really moved things around in a different, or presented them in a different way. But ultimately, it's you screen for them, and if there's a suspicion, you send them for either a DEXA scan or a CT or an MRI for actual quantification of muscle mass in these patients. And really, this was one of the first papers by Fearon et al. That looked at sarcopenia in the overweight and obese patients and whether it has a prognostic factor in pancreatic cancer. And this was one of the first studies that used segmentation by CT, which really is going to become the, for the rest of the talk, the central component of how we look at sarcopenia in this population. And this is just a slide to show you since 2010, since that publication came out, how things have picked up pretty rapidly in this domain. If you look up on PubMed sarcopenia and plus cancer, we see how many publications we reached in 2020, and we're April 2021, and we're already at 200. So we're probably going to go over the amount that came up last year. And back to my point, which I was telling you, I believe that muscle is really the central component to all of this, and the argument for that in the literature, that it is a significant component of our body mass. It accounts for approximately 40%. It secretes myokine peptides that influence insulin sensitivity, our immune function and inflammation and inflammatory response, and our overall homeostatic function. So muscle depletion is not just loss of mass. There are other consequences to that from an immune and an inflammatory response point of view, and insulin sensitivity point of view as well, which ultimately leads to metabolic impairment and a blunted immune response, which can become very important in our domain, especially with Immuno-Oncology drugs that are being administered in the last 7 to 10 years or so. And this is one of the early papers that came out that proposed the mechanisms of muscle wasting in a cancer patient. Obviously, the aging process plays a central role to this and is probably going to remain the main driver of this, along with the patient's comorbidities or ECOG status or whatever term we want to apply to this. But if we look at the cancer-related myopenia or loss of muscle, there's obviously in certain cancers like esophageal and head and neck cancers, they have difficulty feeding themselves, which ultimately leads to cachexia in this setting. But if we look at it from a tumor point of view and how the tumor contributes to it, it's the release of the pro-inflammatory cytokines, which leads to breakdown of muscle and degradation to use and decreased protein synthesis. Certainly treatments like mTOR can impair muscle cell proliferation. And just going, I mean, they talk in their paper about esophagectomies, but when we talk about cystectomies, it will probably have the same impact. Patients don't eat very well post-op. They do have an inflammatory response post-operatively. So there are a lot of similarities there in terms of the stressor from the surgical intervention. There is also evidence that this muscle sequestration or release of amino acids in the circulation even precedes the diagnosis of cancer. And this was looked at a few years ago by a group from Dana-Farber, and they found that a lot of the pancreatic cancer patients have increased B-chain amino acids levels prior to their diagnosis of pancreatic cancer. Now, how are we going to quantify the muscle? Do we just ask for a CT and expect this to be mentioned? Unfortunately not. We're not there yet, but really there is several softwares which are able to segment the intra-abdominal components or the body components. Historically, it's always been DEXA scans, but DEXA scans come with their own limitations, although they're cheaper, but they're not easier to get, especially nowadays in our cancer clinics. I think every patient that comes through the door, or almost every patient that comes through the door, has an abdominal CT scan. And there are a couple of softwares that are out there. I mean, Slice-O-Matic was the first one, I think, that came out, and I think there's another one called Core Slicer, amongst many, but these are the main two that are out there in most of these publications that looked at segmentation. And we see here from the color coding that muscle is red, and we see the psoas and the abdominal component, but it also can look at visceral fat and subcutaneous fat, and even fat within muscles itself. So what do we do with these scans? Do we just segment it and visually assess it? Not really. No, there is what we call a skeletal muscle mass index, which is calculated based on the total skeletal muscle area, and this is divided by height in meters squared. There are other formulas that exist that look at psoas area, other look at total muscle area, and others predict a total muscle volume in the body. And this is based on the Hounsfield units. The segmentation is reliant mainly on Hounsfield units. And this has been validated over and over again that looking at mid-lumbar level L3/L4 really gives a good prediction for the remainder, for muscle mass in the remainder of. There's actually been cutoffs that have been established in the literature. So this is what's been used in the vast majority of the publications over the last 10 years or so. And it's defined as a skeletal muscle index of less than 39 in females, and less than 55 centimeters squared over meter squared for men. More recently, in 2013, there is an adjustment to it, or not really an adjustment to it, but another way of looking at it is by BMI. And although for women it doesn't make a difference, for men there are two separate cutoffs for obese and non-obese men using BMI 25, a BMI of 25 to dichotomize them. And this is just looking at the area under the curve here. For a slice of L4, L5, and the rest of skeletal muscle in the body, and certainly the tissue, adipose tissue in the remainder of the body. So really coming to the meat of this talk, which is how does this impact the surgical outcomes? And this is a paper that was published in 2012 in the World Journal of Surgery, looking at sarcopenia and how it predicts morbidity and mortality after abdominal surgery. It was a meta-analysis of 24 studies with over 5,000 patients in it. And the presence of sarcopenia was associated with a significant increase in post-operative complications with a relative risk of 1.6 compared to non-sarcopenic patients, and a 30-day mortality relative risk increase of 2. And they also found in these papers that looked at survival that 1, 3, and 5 year survival is also worse in sarcopenic patients compared to non-sarcopenic patients. And looking at our own domain in urologic oncology surgery, there's also a systematic review that came out earlier last year, looked at 17 retrospective studies with just under 4,000 patients, and the prevalence of sarcopenia in this population, as defined earlier, was anywhere between 25 and almost 70% in some patients. And they all had significantly shorter overall survival with a hazard ratio of 2, and cancer-specific survival hazard ratio of 2.1. And when on their multivariable analysis, the sarcopenia was independently associated with an increased all-cause mortality and cancer-specific mortality in this population, which is very relevant to our domain. And I'm going to try and break it down with each cancer that we deal with. I'm going to start with localized RCC, and this was a paper that looked at 352 patients with localized renal cell cancer, and the prevalence of sarcopenia was 40%. And they found on their multivariable analysis that it is indeed associated with worse overall survival with a hazard ratio of 1.6. We see here the split of the curves in the overall and cancer-specific survival, and it was statistically significant in both domains. This was a publication earlier this year. And this is another publication by Sutka and colleagues in the Journal of Urology that looked at post-operative, that assessed these patients post-operatively after localized RCC. And they tried to look at the association between sarcopenia and disease progression and cancer-specific mortality. They also looked at 300 plus patients, almost 400. And around the same percentage were sarcopenic at 40%. And they all had significantly higher grade 3 disease, Furman grade 3. Their 5-year cancer-specific survival was inferior, and this was statistically significant. It was 79% compared to 85. Certainly had worse 5-year overall survival. And skeletal muscle index, they looked at it instead of dichotomizing it. They looked at it as a continuous variable, and it did show that the lower it is, the worse it is, and the higher it is, the better. And again, on multivariable analysis, this was independently, sarcopenia was independently associated with increased cancer-specific mortality with a hazard ratio of 1.7. And we see here for progression-free survival, sarcopenic patients fare worse. And as mentioned earlier, for cancer-specific and overall survival, they also don't do as well. What about advanced renal cell patients who undergo nephrectomy and tumor thrombectomy? This was a relatively smaller review, but they looked at 83 patients, and the incidence of sarcopenia was a little bit higher in this population, understandably, as they have more advanced cancer, and it was at 65%. They had shorter cancer-specific survival, 33 months compared to, and was not reached for the non-sarcopenic group, sorry. And the overall survival was 32 months, and it wasn't reached for the non-sarcopenic group. And again, independent on multivariable analysis as a predictor for cancer-specific and overall survival. What about metastatic RCC? They looked at it again in a similar setting. Again, smaller study, 68 patients, 64% incidence of sarcopenia, and they all had a worse MSKCC score, and their 3-year overall survival was 31% compared to 73%, which was quite a stark difference there, which was also statistically significant. They somehow managed to do a multivariable analysis with such a small sample, and it turns out that it is an independent predictor in their case with a hazard ratio of 2.5. In fact, at the end of their paper, they advocated for integration of sarcopenia in the MSKCC index. We see here that stark difference with quite a wide split there in the Kaplan-Meier curves. And I added this study because I wanted to look at treatments in these patients, and this is actually quite relevant to what I'm claiming is the central component of all of this, which is muscle. And here they looked at the relationship between muscle loss and progression of disease on patients treated with the sorafenib. They looked at 80 patients. Incidence of sarcopenia was understandably high because of their advanced disease, and they looked at it, they randomized them to sorafenib versus placebo. And they looked at the muscle loss in the sorafenib group, and they have a more rapid muscle loss at 6 months with a decrease of almost 5% and almost 8% at 1 year. And this was statistically significant compared to patients that were on placebo. And this is really consistent with the previous evidence that kinases regulate muscle mass. We know that the mTOR and the ATK pathway, if it's overexpressed, it can lead to muscle buildup, and if it's suppressed, like these patients that are on VEGF inhibitors, it will probably lead to muscle wasting. This is another paper that looked at sarcopenia in the metastatic setting in RCC, and they assessed the impact on progression-free survival. Again, a smaller paper, 54 patients, looked at treatment with cabo, and they assessed it with 2 CTs, one pre-treatment and one after treatment, and they found that on multivariable analysis, patients who lost more than 10% of their skeletal muscle had much worse progression-free survival with a hazard ratio of 4. So what about urothelial cancer, bladder, or cystectomy, the big one? A lot of research in this area from a frailty and a sarcopenia point of view. And really in a radical cystectomy setting, there were 6 retrospective studies that looked at this, and the incidence of sarcopenia was anywhere from 25 to 70%. All 6 of them showed worse perioperative outcomes in terms of length of stay in the hospital, post-operative complications in the first 30 and 90 days, and even mortality. And 5 of the 6 studies showed significantly worse overall survival and cancer-specific survival. And the one that actually didn't was a study that looked at psoas muscle area rather than skeletal muscle index. And even then, it did show a trend towards worse outcomes and much shorter follow-up as well. I'm going to give you examples from the largest 2 of them, largest 2 studies out of the 6. And this study was published by Mayer in 2018, and we can see quite a stark split there in their overall survival and cancer-specific survival over a period of 5 years. And if we look at the hazard ratios, we look here at presence of sarcopenia, which has a hazard ratio of 1.4. This is almost as bad as having T2 disease, or just below having node-positive disease in terms of its ability to predict poor outcomes from a cancer point of view. This is another publication by Sutka and colleagues that came out in 2014. This looked at 200 patients. And similarly, sarcopenia does have a big impact here on multivariable analysis. The hazard ratio is at 1.9. And if we look further down, this is almost equivalent to having muscle invasive disease and worse than having a poor ECOG performance status, which is really another way of assessing frailty and Charlson comorbidity scores. And all of these, it was a stronger predictor for patients doing worse. So there was a meta-analysis that also included upper tract patients in the same setting, and there were 12 studies that comprised about 2,000 patients. So they were all retrospective, and there was a degree of heterogeneity found amongst these studies, but and also some discrepancies at how they looked at sarcopenia, what measures they used, and how they looked at the outcomes. But if we look here, I mean, we see the trend is always going towards worse outcomes from an overall survival and a cancer-specific survival point of view. And we look here when they sort of tried to break it down into groups. We look at in the upper tract group, and we see here that the hazard ratio is at 2.53 for overall survival in the upper tract domain, and for cancer-specific survival is at 2.6 hazard ratio, which again goes to show similar findings. What about systemic therapies in locally advanced and metastatic urothelial cancer? We know from this publication that they looked at the relationship between sarcopenia and neutropenia in patients that were given gemcitabine and cisplatin in the neoadjuvant setting, or upfront to downstage patients who were locally advanced. They looked at 80 patients, and sarcopenia was an independent predictor for cessation of treatment due to neutropenia, with an odds ratio of 3.5. This is another paper that looked at pembro in the same setting with patients with advanced cancer. Now, this is a much smaller study with 28 patients, and again, around 70% of them were sarcopenic, but overall response rate was significantly higher in the patients without sarcopenia. And the progression-free survival was also significantly shorter in patients with sarcopenia, with a median of 3 months versus 15 months. And it's a very small study. I mean, there's a statistically significant difference, but again, only 28 patients. So it's a very preliminary evidence in this domain. But this is a very nice sort of plot that shows the difference between the sarcopenic and the non-sarcopenic patients from time of initiation of treatment and time of progression occurrence. And we can see the trend here is everything happens earlier in these patients with sarcopenia compared to their counterparts that are non-sarcopenic. What about prostate cancer? So I think the idea gained a lot of traction in this domain, and people started looking just randomly at all the cancers that are out there. And this was a publication that was that came out in 2018 by the group from Mayo Clinic, and they looked at radiologically diagnosed sarcopenia in just under 700 patients that underwent radical prostatectomy, and they looked at biochemical recurrence, progression, and all-cause mortality, and there was no significant difference actually in perioperative complications between sarcopenic and non-sarcopenic patients. And in multivariable analysis, the presence of sarcopenia was not significantly associated with the risks of any of the endpoints that they looked at. And they say sarcopenic patients were older, but 60 to 63, I don't think that's a significant difference from a clinical point of view. And again, another group looked at it and looked at functional and oncological outcomes, and in fact, there was no impact of sarcopenia on erectile function or recovery postoperatively, and there was no correlation with localized disease. However, the gears switch a little bit when we go into the metastatic domain. This paper that looked at the prognostic impact of sarcopenia in patients with hormone-sensitive disease looked at 167 patients, and 82% of them were actually sarcopenic. This is the highest incidence we have in all the cancers that we talked about so far. And the cancer-specific and overall survival were significantly shorter in the sarcopenic group, with a median of 77 months and 72 months in the sarcopenic cohort, and not reached in the non-sarcopenic. And multivariable analysis showed that it is an independent predictor for cancer-specific survival. This is just a slide that I borrowed from an online presentation showing a patient pre-initiation on ADT on the left, and we see how much muscle is there. And this is 2 years later, where there's a significant loss of muscle mass just on CT. And I don't think we need a software to tell us that there's a significant muscle loss there. Now, whether this is just the impact of ADT only or the disease itself, it's not very clear, at least certainly not in the literature clear. But there are mice studies that looked at the impact of ADT, and it does show that it can lead to muscle wasting, which we already knew and we counseled our patients about. And in the castration-resistant setting, these body composition assessment and advanced disease by this group, the publication came out in 2010, assessed the impact on overall survival. Again, retrospective, of course, 186 patients, all castration-resistant prostate cancer on docetaxel as first-line therapy with 2-year follow-up, and their multivariable analysis, low skeletal muscle index was associated with disease progression in this group. This is another group that looked at it with a different outcome, looking at tolerance, and it seemed to have had more toxicity after 3 cycles in sarcopenic patients. It was a small group, 63 patients, but there was dose-limiting toxicity experienced in 60% of the sarcopenic patients versus only 30% in the non-sarcopenic. And this was statistically significant. And as we mentioned earlier, higher incidence of neutropenia for those patients, similar to their bladder cancer counterparts. However, there was no association in this particular paper with the overall survival. So, if we look at it as a biomarker, sarcopenia, I think there's a lot of limitations. Certainly, the definition is not finalized yet. It's still being refined. The measurements, methodologies are still different, and people are working on different ways of measuring them. And certainly to be used as a screening tool, there isn't really anything out there that we would consider a gold standard yet. There is some variability in their outcomes. We see in prostate cancer, it doesn't appear to be impacting the outcomes very much, but in bladder and kidney, I think the evidence across all the studies show that these patients fare worse. And also looking at it just from a sarcopenic, non-sarcopenic, this black and white dichotomization, I think we end up losing some patients in there. I mean, someone with a male patient with an SMI of 54 the same as a male patient with an SMI of 44, and they're both considered sarcopenic. I'm not sure. I think there's probably more work to be done into maybe dividing them into further groups. And I know in my earlier the slides, I said that it's a very easy software to use, but it's not one click away. I mean, I can't do this in the clinic. I have to get the DICOM file, transfer it to the software, look at the values of the Hounsfield. And although one of the softwares is automated, it gives you the numbers, you still have to take the values and calculate what the SMI is. And certainly there aren't any prospective studies that looked at this, at the use of this in a clinical setting. What about reversibility of this sarcopenic state or the frail state, and what interventions are out there? I mean, exactly like frailty earlier, there's three broad categories that look at it. It's physical exercise, whether it's an aerobic exercises or muscle strengthening exercises, which both have been shown to be good in a cancer population, nutrition and supplementation, and medical therapy. In terms of physical exercise, it's always going to be a multidisciplinary approach. I mean, there are 3 papers in bladder cancer looking at prehabilitation of these patients, but unfortunately, there isn't much out there in terms of whether it impacts outcomes or not. They're all feasibility studies, and they do show that it is indeed feasible, but nothing came out that looked at outcomes post-cystectomy or post-systemic therapy. Although one of them did show that these programs are feasible during chemotherapy. I think it was 70% of patients that were able to do the exercises while being on chemotherapy. And looking at nutrition and supplementations, like most of the supplementation literature, there's mixed results. Some people will think vitamin D fare very well, and others don't show that it has any impact on anything. And in similar fashion, in this research domain, there isn't really anything out there that is included in any of the guidelines or any gold standard approach to it. However, there is what we label as Immuno Nutrition, which was looked at by Hamilton Reeves in a publication that came out in 2018 in Journal of Urology. And they randomized a very small group of patients. I think it was 28 patients, 14 in each arm, to a Immuno Nutrition supplementation, which was, I think, used 5 days preoperatively. And this did show a counteraction of T helper cell disruption and a lower inflammatory response when they looked at the level of interleukin-6 and T helper cell levels. And from a clinical perspective, there was a 30% reduction in post-operative infections in the first 90 days. So I think there is something there, although it's a very small study. I think certainly this is something that could be expanded on. And from a medical therapy point of view, there's the selective, just 1 second, please. Sorry about that. There's selective androgen receptor modulators, which have been around for some time and looked at in different settings, in postmenopausal urinary incontinence and supplementation for muscle building, and looked at for breast cancer patients as a hormone replacement without the side effects. And essentially, they work as an agonist on some tissues, such as bone and muscle, and as an antagonist in other tissues, mainly the reproductive organs. And there is evidence that they do increase muscle mass. However, this hasn't translated into increase in strength. And certainly there is a growing body of publications that show some liver toxicity associated with these drugs, especially the earlier compounds that came out in the early 2000s. So all in all, nothing really out there that meets or ticks all the boxes for as an intervention. I think the future is likely going to be in combination therapy when we approach those patients, and it's probably going to be a part of a prehabilitation protocol prior or while being on treatment, or maybe preoperatively. So just to bring it all together, I think the take-home message here from this is, frailty, whichever way we want to define it or put it, does have a major negative impact on surgical oncology patients, especially in GU oncology. Sarcopenia as a surrogate works very well to screen patients, and it's obviously predicting well who's going to do. It's predicting who's going to do well and who isn't. But I think we need to start looking at it differently. Do we start triaging patients based on sarcopenia, or do we include this in our as a factor when we're counseling patients about, I don't know, a radical cystectomy versus chemoradiation? Certainly, it's still a research area in its infancy. There's a lot of research avenues to be explored there, especially the immune component of this. I mean, if these patients are not mounting a strong enough immune response, are they good candidates for immune oncology? Are they we don't have to look at muscle invasive bladder cancer. What about patients who we're giving BCG? Is this going to impact giving BCG to these patients? These are questions that we don't know the answer to. But ultimately, this is a multidisciplinary problem. This is not going to be addressed by, certainly we can't address this in our clinic alone. This needs a team to be looked at. In terms of the therapeutics, as we showed, there's some promising results certainly from a nutrition point of view, but data still lacking across the board. And I think I've created more questions than answers with this talk. But I do believe that there's several avenues of research that could be explored there. Thank you very much for listening, and be happy to answer any questions.